I'm going to talk today about ocular rosacea. I was asked to give a talk on this because I don't know that I would have ever chosen this topic. In fact, as I started thinking about what I was going to talk about with regard to ocular rosacea, the only title that came to my mind was Ocular Rosacea, Useful but Boring. And I started putting together the talk, and actually as I started reading about ocular rosacea, I found some really interesting things. And so I just wanted to share those with you today. The other thing that researching ocular rosacea taught me is how to explain this disease to patients. And by understanding the mechanism of the disease, you can understand a lot of the treatments that we use for the disease. So let's get started. This is a painting by Domenico Ghirlandaio, who is an Italian Renaissance painter, was a short-term mentor to Michelangelo. And this painting was painted in the mid-1400s. It's now housed in the Louvre, and it's called The Grandfather and the Grandson. And what you can see here is that this grandfather has rosacea. You can see he's got rhinophyma, the lumpy, bumpy nose. You can see the spider telangiectasias on his forehead. And you can even see some puffiness of his eyelids. Well, you may think that this is a very early recollection of the disease rosacea, but actually rosacea was first seen in the artistic world in 1387 when Chaucer wrote his Canterbury Tales. He wrote about several people who went on this journey together, and one of them was a summoner. He was an officer of the church whose duty it was to ferret out delinquents in morals, especially in matters of fornication and adultery, and to bring them before the ecclesiastical courts. So this is what he wrote. I'm going to attempt to read it in Old English, but I haven't spoken this for a while, so I'll do my best. A summoner was there with us in that place that had a fire-red cherubinous face. For sauciflame he was, with eyen narrow, as hoot he was, and lecherous as a sparrow. With scalded brows black, and piled baird, of his visage children were affair'd. There nas quicksilver, letarge, ne broomstone, boras, seru ne oil of tartar noon, no ointment that would cleanse and bite, that him might helpen his welcus white. Nor of that nobbas sitting on his cheeks, well loved he garlic, onions, ich leeks, and for to drinken strong wine red as blood. And so what you can see is that they not only recognized the features of rosacea in this man, they also started thinking about what he was trying to use to treat his affliction. And if you didn't understand the Old English that I read, what he was trying to use were a mercury, protoxide of lead, brimstone, borax, white lead, cream of tartar, and arsenic ointment. So that's 1387. Then we've got another reference in the 1400s. And then in the 1500s, actually 1600s, we see again rosacea appearing in the art world. So this is a famous painting, Abraham and Isaac. Does anybody know who did this? Rembrandt, exactly. So Rembrandt van Rijn. And while neither Abraham nor Isaac had this picture, Rembrandt was also famous for doing self-portraits. And what you can see here is Rembrandt as a young man. You take a look at his facial features, because as he aged, he developed progressive signs of rosacea. So you can see his red cheeks. Again, you can see the baggy, puffy eyelids and his more bulbous nose as he aged. So a couple fun things about rosacea, but now we have to get down to business, and then I'll make it fun at the end, I promise. So what I want to do is present the pathogenesis of rosacea. Again, I have a lot of patients who ask, what is it when you tell them they have rosacea? And so I wanted to be able to give those patients an answer, and I found a good answer, so we'll talk about that. to describe the symptoms and findings in ocular rosacea, and then to discuss some treatment options. So what is rosacea? Rosacea is a common skin disease. In a Swedish study that stated a prevalence of about 10%. We have a high population from European descent here in Wisconsin, and so I kind of calculated on an average day we might see 3 to 4 patients with rosacea. Sometimes we may not even know that we're seeing them, and I'll drive that home with some celebs at the end who you may not know have rosacea. But it's more common in fair-skinned individuals, Northern Europeans, which is why it was called the curse of the Celts. Interestingly, the fairer the skin, the more likely the patient would have rosacea. I do want to point out, though, that 4% of rosacea patients will have darker skin, so it's not something to completely rule out based on race. Women are 3 times more likely than men to have it, and the peak severity is when women are very, very young, like me. I keep telling myself that. So what is it? Rosacea is multifactorial. It's vascular hyperreactivity. And I just jotted down what I thought was the best sum of rosacea. So I'm going to read that, and I'm going to read it twice just so that you can store it in your heads and tell this to patients. So rosacea is a neural disease where normal vasodilation is greater and more persistent. It then has an autoimmune component where minute amounts of extravasated plasma induce a dermal inflammation. With repeated vasodilation, the telangiectasias form and the redness develops. With repeated bouts of inflammation, fibrosis and hypertrophic scar tissue is produced. So one of the things that we talk about for the first way to treat rosacea is actually to avoid the exacerbating factors. Because if you can avoid these bouts of reddening of the complexion or flushing, you're actually going to have less progression of the disease. So what things should we tell patients to avoid? Hot foods. Foods high in histamines, like red wine, aged cheese, yogurt, beer, cured pork products, and then also, if you can avoid steroid medications in these patients, that's helpful, although we'll talk about sometimes when you actually have to use them. Some environmental factors to avoid: temperature extremes, strenuous exercise, heat from sunlight, sunburn, stress and anxiety, cold wind, and changing temperatures, so going from a cold environment into a warm environment. So basically, we need to tell these patients to move south. So we talked about the fact of what it is. What it isn't is it's not an endocrine disease, and it's not a microbial disease, although it was once thought to actually be related to Helicobacter pylori. It is not purely Demodex, although it, again, was once thought to be related to Demodex. This is a Demodex. And Demodex is a little arachnid. You can see it has a little tiny head. It's got 8 legs, and then it's got a nice long tail. Demodex are light averse. They hate light, and so what they do is they hide down in the follicle with their little butts sticking up in the air. And then at night, when you're sleeping, they crawl up, the boys crawl up, and then they go and they find another female who's hiding down in a follicle. They mate, and then they crawl back into their follicle. The female will lay 15 to 20 eggs once in her lifetime. The life cycle is about 2 to 3 weeks. And these little Demodex can crawl about 1 centimeter an hour, which is impressive. Here's a hair shaft with 2 Demodex. I don't know, do we have a laser pointer up here? Oh, yeah, right here. So here's the hair shaft, right here. And here are the Demodex. This is the tail of one, and then you can see starting to get into the leg segments. And then again, there's the tail of the other, and then the leg segments up here. This is the collarette. So Demodex produces a very typical cylindrical collarette. And what that collarette is, the reason it's pathognomonic for Demodex is that the Demodex, as they crawl on this hair, they actually induce trauma to that hair with their little legs. And then keratin and oil accumulate right there at that area on the hair where there was the trauma. So why was Demodex once indicated as a cause of rosacea? Well, it involves the same area of the face, kind of the T-zone, the cheeks, the forehead, the nose, and then the eyelids. There are more Demodex mites in patients with rosacea. And Demodex causes a localized folliculitis, which rosacea did as well. Why is Demodex not solely the cause of rosacea? Well, it doesn't respond to rosacea treatments. And rosacea doesn't respond to lindane, which is the treatment for Demodex. So I was once asked to treat Demodex. I had a consult on my schedule that said, for Demodex infestation. And so I did a little research, and I actually walked in feeling like I had a good plan for this patient. And we treated her for 1 month. And when she came back, the treatment had actually worked. So my first time treating Demodex, it actually was highly successful. What did I treat her with? Well, I treated her with tea tree oil. Okay, I had her go out and get tea tree shampoo and had her do the usual Blepharitis treatment, but instead of using baby shampoo, I had her use tea tree shampoo. And it caused marked improvement in her. Tea tree oil really is the best treatment for Demodex that we have at this point in time. You can get tea tree ointments compounded by pharmacies, or you can make a tea tree oil treatment, which you use in a 20% mixture with either macadamia or walnut oil. It does sting, and so this would be an in-office procedure if you were going to treat that with the oil. Easier just to get the shampoo. An in-office treatment because then you can give them proparacaine. So rosacea has several subtypes and variants, but there is the vascular subtype where you just get these little telangiectasias on enhanced and UV exposed skin, so especially in the nasal ala. And then papulopustular rosacea. This is what was commonly referred to as acne rosacea, which is a misnomer. But you get persistent erythema, and then you get these papules and pustules, which are more of an acute inflammation. Now, what you can get in response to that is more of a chronic granulomatous inflammation, where you actually get granulomas, firm brown, yellow, red, uniformly sized papules and nodules. The variants of rosacea are sebaceous hyperplasia, where the rosacea and that extravasated plasma has actually caused so much tissue swelling that it actually closes the pores, and these pores become dilated with keratin. And so then you get this inflammation, and you end up with this really thickened skin with irregular surface nodularities. And then we'll also talk about, obviously, ocular rosacea at the end of this. But what you can see here are rhinophyma, again with those little dilated pores because of all the inflammation that happened in this tissue and all the swelling, and otophyma. And again, you can actually see the pores in the ears, which I thought was a neat picture. So, of course, I had to include this in my talk. This is the histopathology of rosacea, and what you can see is that there's a perifolliculitis here, and probably evidence of perivasculitis too, where you're just seeing these clumping of lymphocytes. So the topical treatment for facial rosacea involves metronidazole really as the first-line agent, and azelaic acid. But the other thing that I thought was interesting is this sodium sulfacetamide wash. Sodium sulfacetamide is used very commonly in dermatology. You can buy it as a wash, but you can also buy it as towelettes. A dermatologist that I spoke to about this topic said that it does not cause eye irritation, and that she has actually had a lot of success having patients use this for lid scrubs. So if you're failing with the baby shampoo, something to consider would be sodium sulfacetamide, because it has antimicrobial properties, but also has keratinolytic properties. And there is no cross-reaction with sulfa allergy, so it's safe to use. So the second-line therapies in facial rosacea are benzoyl peroxide, clindamycin, some antibiotics, retin-A, permethrin, tacrolimus or Protopic, and topical steroids, but for very short periods. They also will often use oral. And tetracyclines, as we all know, are the main first-line oral agent for rosacea. The way that they work is they decrease chemotactic responsive neutrophils, they inhibit granuloma formation, and inhibit protein kinase C. So all things that would make this rosacea worse. The side effect profiles you can see here, minocycline has fewer than doxycycline, which has fewer than tetracycline. And the burst and taper, you could do a burst and taper, or you can just start out with 40 milligrams, the extended release from the get-go, and keep them on that long term. The oral treatment is also erythromycin, azithromycin, metronidazole, and clarithromycin. Again, these are second line. 3,000 to 4,000 milligrams, so 4 grams of omega-3s, tapering to 2 grams. And I've actually tried this in my ocular rosacea patients, just doing the omega-3s really high for a little bit and then tapering them down. And then oral retin-A, basically, for refractory nodules and rhinophyma. And then oral steroids, again, very short term, just for the lymphedema. But what we normally say is that if you can get them on a topical and small oral dose, that combination is going to be best for the patients. They do have some surgical treatments, mainly to reduce the effects of rosacea, not to treat the rosacea itself. And we don't need to go over these because we're not dermatologists. So ocular rosacea. Ocular rosacea is actually found in 1/3 to 1/2 of rosacea patients. Whereas facial rosacea has gender predilection, ocular rosacea has no gender predilection. And 20% of patients will actually present with ocular rosacea. We find that these patients have an increased interleukin 1A and promatrix metalloproteinase within the tears, which can cause some of the findings that we see. But the pathogenesis of the eye findings is that vascular permeability, again, causing dermal edema and inflammation, meibomian impaction, just like it impacts the sebaceous glands on the face, decreased lipid in the tear film instability, and then the irritation. Interestingly, the eye disease is not related to the severity of the facial disease. This I'm not going to go over, except for the fact that I just want to show some of the retina specialists here that dry eye can be categorized into both aqueous deficient and evaporative components. And you can see the evaporative component is the one that we're worried about in rosacea with meibomian gland disease. And then you can see meibomian gland dysfunction here has 2 different types. It's got low delivery and high delivery. And both types, you can see acne rosacea here, right here, because it does cause that sebaceous hyperplasia, but then also causes that dermal inflammation and the blockage of those glands. So the symptoms in eyes are burning, dryness, we all know these, tired eyes, edema, fullness of the lids and fullness of the face are things that I didn't think about necessarily with rosacea, but are very common and make sense once you know the etiology. Tearing, pain, blurry vision, and then chalasia. And the manifestations come to us as blepharitis, meibomian impaction, styes and chalasia, conjunctivitis, keratitis, a keratoconus like inferior corneal thinning, again because of that matrix metalloproteinase, flictenulosis, corneal neovascularization, ulceration, and then ultimately, but hopefully not, globe perforation. So our treatments are artificial tears, NSAIDs, which I haven't used much in these, but these are just things that I found. Topical corticosteroids, a main one would be the antibiotic steroid drops and ointments, azithromycin, azocyte, and cyclosporin. And obviously you want to treat what's going on in the patient. So for blepharitis, the warm compresses and eyelid scrubs I generally will have patients do the warm compresses for 3 to 5 minutes, thinking of myself as a busy person. I just feel like you can't put too much pressure on these patients because then they'll just throw it all away. So 3 to 5 minutes, but you do need to raise the body temp 5 degrees to liquefy these meibomian gland secretions. And then the baby shampoo, but now we've learned that we could also try sulfacetamide or in patients with Demodex, tea tree oil shampoo. And azithromycin, which I have generally used like this, twice a day for 2 weeks, once a day for a month, and once a day for 1 week out of each month. And then topical cyclosporin, which makes sense because of the inflammatory component here, that an anti-inflammatory might work. So we know how to treat styes. We'll skip over that because we're coming up to a fun part here. So for dry eyes, lubricants and with or without preservatives, again, the cyclosporin I think does make sense when you think about it. Vitamin A drops, topical steroids, short term again only. But these patients may require punctal plugs. Interestingly, in rosacea patients, you don't necessarily think of them as having decreased tear production, but they can. In fact, they did a Schirmer test between patients who had ocular rosacea and those who didn't. And where the ocular rosacea patients actually made 14 millimeters of tear, the average patient make 21. So they still are more aqueous deficient than the average patient. But also, not surprisingly, the tear breakup time was about average of 8 versus 14 seconds in the rosacea patients. And then systemic medications. So we use tetracyclines because of the anti-inflammatory properties. We've been using them since the 1960s. They do decrease bacterial lipase to improve the fatty acid composition. Patients will always ask, why do you use doxycycline? So I found this useful. It also inhibits collagenase to protect the cornea from sequelae. And then what you can see here is that this is a dose of doxycycline, starting at either 1 to 200 milligrams twice a day and then tapering. But this extended release, which is 40 milligrams, can be started and then also used for maintenance. I haven't done that much, and we can talk about it at the end if anyone wants to chime in and see if they've used it successfully. The common potential side effects are just important to remember whenever we're prescribing a systemic medication, and include GI upset and diarrhea, increased susceptibility to sunburn. That's very important. And the lips can get sunburned. I had a patient who went skiing and put sunscreen all over her face and didn't protect her lips, and she came back with bright red burned lips. Pancreatitis, pseudomembranous colitis, renal tubule damage, pseudotumor cerebri, again a concern of ours, and then fetal and youth bone growth retardation and permanent tooth discoloration. We all learned that when we were in medical school. We do have some surgical treatments, penetrating keratoplasty if it comes to that, limbal stem cell transplants, punctal occlusion and cauterization, meibomian gland probing, and meibomian gland thermal and mechanical stimulation. These might be new to you. But this is a masket meibomian gland probe that you can stick in the meibomian glands that are insipated, and it's okay if they bleed, is what the instructions for this say. And I was like, oh, that would be very painful. But then this is also a Mastrata paddle that you can use. We do sometimes techniques a lot like this when we're massaging the meibomian glands, but this looks like an interesting little instrument to use. And then this is an interesting machine which I found in a throwaway journal, which provides some thermal stimulation there, and then also this kind of pulsating mechanical thing that would happen to your eyelids. It looks like it might be kind of comfortable, actually. Kind of relaxing. But one thing that we can truly do with rosacea patients is we can reassure them. We can reassure them how common this is. We can tell them that they're in good company. We can tell them that they're in the company of millionaires. This is J.P. Morgan, who once paid $100,000 to have someone not take his picture because he was so conscious of his appearance. Pop stars, Mariah Carey. Talk show hosts, Rosie, fitting name. Movie stars, both old, W.C. Fields, and new, Renee Zellweger, Cameron Diaz. Presidents, Bill Clinton, and princesses. That's the end of this talk. Thank you.